Do you find asthmatic persons to later be diagnosed with sleep apnea?
Okay, yes, very good question. I didn't mention, but some individuals with asthma, you cannot control their asthma unless you control their sleep apnea if they have sleep apnea. Because what happens is with the sleep apnea, you're going to microaspirate, meaning small amounts of content from your stomach is going to travel up your food pipe. It's going to slip into your lungs, including acid from the stomach, and that's going to lead to bronchospasms or tightening of the airway. And so individuals, particularly the obese who have sleep apnea, it's very important for us to look and see if they have sleep apnea and correct it in an effort to control their asthma. So sleep apnea and asthma is also known as complex, and COPD is also known as complex sleep apnea because you have overlap disease, which makes the situation worse.
Okay, so Dr. Moss, do you find where some persons with obstructive sleep apnea have hyperventilation disorder when they're in closed areas or anything of that sort? Elevators, small rooms?
No, there's no direct correlation to hyperventilation syndrome and claustrophobia and sleep apnea, not direct, okay? Remember, sleep disordered breathing is when you are asleep, okay? When you're awake, you're good, okay? Issue is when you fall asleep and you have relaxation of your upper airway muscles that you lose that tone, then it's easy for you to close off. But once you're awake and your muscles are patent, the air from the environment can pass your upper airway, get to your lungs. You can expel your carbon monoxide quite freely. Now, some individuals with sleep apnea also have obesity, hypoventilation syndrome, and they tend to overlap as well. Now, those individuals with obesity, hyperventilation syndrome, they can hypoventilate during the day, okay? How are we gonna differentiate between obesity, hypoventilation, and pure sleep apnea? Patients with obesity, hypoventilation, if you do a blood test on them for carbon dioxide, their carbon dioxide is always elevated, or most of the time it's going to be elevated. But an individual who have pure sleep apnea, because they're good during the day, they can blow off their carbon dioxide during the day. The issue is at nights when they don't have that conscious effort to take those deep breaths, then they may have issues with their carbon dioxide. Okay, so obesity, hyperventilation, and obstructive sleep apnea, we also term overlap syndrome.
Okay, all right. And we have G91 Pro is asking, because I had a sick child for years, I didn't sleep well. She's now older, but I find myself can't sleep well. And I'm so tired in the morning and my feet becomes restless. What can I do?
Okay, first, you need to do a history and get all the details, examine and see if there's some structural, do you truly have sleep apnea? But just poor hygiene. Sleep hygiene can make you tired during the day. It doesn't have to be sleep apnea. Doing shift work, one day you working 8 to 4 p.m. Then your supervisors switch you to 8 p.m. to midnight. That type of nonsense. It disturbs your circadian rhythm. So your normal sleep pattern that that normal individuals would have, in your case, would be all interrupted. So your brain doesn't know what to do, and so 2 in the morning, if you not accustomed to being taking your regular rest at a certain time, you wide awake, and then you start thinking about all the stress in the Bahamas and all the stress with the children in school and them bills that you didn't pay and this one you forgot to make contact with, and so you don't sleep. But it doesn't mean that you have sleep apnea. It's just poor sleep hygiene, and so we advise or we recommend to patients that you have a set going to bedtime and try to have a pattern. Even if you have sleep apnea and you have help with a CPAP machine, we still recommend that you have a regular sleep pattern and you take all of the noises out of your bedroom. You argue with your wife to take the TV from Home and Garden TV so you can sleep. All these little things, being in a dark room, all these little things help. And so it doesn't have to be sleep apnea, it could just be the sleep environment that's impacting the individual. And so we have to look at the whole picture.
Okay, we have quite a few more questions in the chat. Can a sleep position reduce snoring?
That's very true. And so we advise individuals with sleep apnea that they sleep on their side, okay, and on their abdomen, okay. But we try to avoid, or we tell them to try to avoid sleeping on the back, because when you're on your back, you tend to obstruct more, okay? So you have the weight, especially if you're a little on the heavy side, you have the weight of the chest, the weight of the abdomen, a relaxed neck. That all portends to having obstruction in your upper airway. So being on your side is always the best position. Sometimes it takes a little getting used to sleeping on the side or sleeping on the abdomen. But they are the better positions to be in when you have obstructive sleep apnea. Now, when we do a sleep study, a titration study, we want to see the patients in different positions. Okay, that's what the belts help to do. It gives us your body position, whether you are lying supine, whether you're on your side, whether you're in your tummy, it all registers. And so we would like to see the individuals in the different body positions, because if they go on their back, then we can titrate the pressure so that should they go on their back, they would still be corrected. If they're on their side, they would be corrected. If they're on their abdomen, they would be corrected. But we still encourage individuals to, sleep on your side. It'll be the favorite position anatomically to prevent you from obstructing.
Okay. And how can have you heard about GABA, valerian root, and melatonin combined? Would this be effective for sleep?
Yeah, I've heard, but I'm not a bush doctor, but off the record, yeah, valerian root supposed to help to relax the individuals and give you better quality sleep. But I'm by far no expert in that, and that's just from little reading and little hearsay. So don't take that as gospel from Moss, okay?
All right. If a person diagnosed with sleep apnea about 2 years ago did not pursue treatment for it, would such a person have to do the sleep test again?
In the ideal world, yes, particularly if the individual has gained weight. Okay, because if you gain weight, the test that you did 2 years ago is sort of kind of history in terms of the correction. It would have changed. But there are auto-titrating machines now that we can use to sort of, should I say, guesstimate what the pressure. We can set a low pressure and a high pressure, and then we can see where the patient falls in the middle, and it gives us a better idea where we can set. Okay, it's not ideal, but I call it a poor man's titration study, where you can sort of guesstimate until you get it right. But ideally, you want to do a titration study so you can know precisely where and what modality to use to correct the individual's sleep apnea. So the answer to your question is, you should be titrated over in order to know where you're at this particular point in time.
Is there a relationship of sleep apnea to dementia?
Yes. So with sleep apnea, one of the complications or one of the things that happen is vasoconstriction or vasospasms. Okay, so your low oxygen level and your high carbon dioxide level is going to cause your blood vessels to get tight. And so when you have a tight blood vessel, then the blood flow to your brain is going to be lower and slower, okay? And you need good oxygenation to your brain in order for you to process. And so having low flow or low oxygenation to the brain is purported to be one of the mechanisms why individuals get dementia.
And the contact with Dr. Moss will be shared at the end of the presentation. But Dr. Moss, can you just confirm your location? Persons would like to know your location, please.
Okay, so I'm in Palmdale on Montgomery Street, in Kevia House. And on the door, you would see Pulmonary and Critical Care Institute, Bahamas. And there's a big sign up on the wall too that says Bahamas Sleep Center. But in the front of the building says Kevia House. So it's on Montgomery Street, number 6, Montgomery Street.
Okay. And the average cost of a sleep apnea testing along with the CPAP machine, not using insurance.
Plenty money.
Okay.
Go on.
All right.
No, seriously though. No, seriously though, it is expensive, but we try to, patients who can't afford, we tend to, do a minimal price, like operational price for them. And it's like $1,000 and $1,300 and I want to say $75, which is like just the cost of doing the test with you know, paying the staff and facilities and all that stuff.
Okay.
But the real price by the code is about $2,000 and something, 2,000 almost three, yeah, by what it's supposed to be called, what it should cost in reality.
Okay, and are your covered services covered by NHI?
Not yet.
Okay. And we have a participant that's saying, I am 5'2" and weigh about 175 pounds. Even before I was this weight, I remember being awakened from my sleep because of choking, sometimes 2 to 3 times at night. Is the sleep apnea really due to my weight?
Okay, you're 5'2", that's it. Male or female?
175 pounds.
Male or female?
Carisha, I'm thinking female, Carisha.
Okay, 105, 2. That's 10.
5'2", 175.
Okay, and then I give you 12 more pounds for 2 inches. For the 10%, that's 7, 2, 127 pounds. You overweight, ma'am. I don't want to say you're obese, but yeah, you get there.
My weight then.
Yeah, no, you overweight, and so if you have an interrupted sleep, it should be, you know, at least you consult and see what's up, and then go from there. But you're way overweight.
Okay. So what is needed to regulate the air pressure in the CPAP machine?
Okay, so I didn't go over that, but
Oh, sorry. Okay.
yeah, I didn't go into details with that, but with the CPAP machine on the study, as the individual is sleeping, we do what we call a titration. So using the lab machine, the lab CPAP machine, we can adjust the pressure. We go like by 2 centimeters of water pressure each time, to see if we can get them to stop snoring and stop having the apnea. So when they stop having the apneas, we can see normal brain waves, we can see no obstruction, the oxygen will no longer be falling. And so once we achieve that pressure, then we know that we got you. You know, we have the problem corrected. And so we take the same information that we got from the study and we program it into the CPAP machine, whether it's CPAP, whether it took BiPAP to fix you, or if you were having like a lot of central apneas, like your brain wasn't sending the signals, you get central, we'd see what, how much of it you had and what pressure it took in order to correct, to stop you from having those central apneas. And so that information that we learned from the titration study, we program it into your machine, and then once you wear it, we know you're good.
Okay. We have another person giving height and weight, 5'11", 168 pounds. I have been diagnosed with sleep apnea since 2013 and have since had a stroke in each of these years, 2013, 2015, and most recently, May of 2023. Why?
Okay. All right. So me or whoever did your study, we need to look at your chip, your data card, and see if you are corrected or not. Okay. But now remember, not only sleep apnea can cause strokes. Okay, so we have to look at the whole picture. We have to try to find out why is it that you're having strokes. Okay, is it something inherited? Is it something with vascular malformation in the brain? Do you have other medical issues that is predisposing you to having strokes? So we have to look at the whole picture. Your sleep apnea may be corrected, but then there's something else that is causing you to have strokes. And if you're a young person, then you know it'll be very important to look for like collagen vascular disease. Like, is there something collagen vascular that's predisposing you to having recurrent strokes? Okay, and it may not be the sleep apnea. Okay, or if you do have sleep apnea, did you put on weight? And the pressure setting on your machine is no longer correct. So first thing is, let's look at the chip and see if you're still corrected. And then we, look at your history and see if we can find another reason why you're having your strokes, and see if there's a fixable reason why you're having strokes. But one thing that your question brought to my mind that I did not mention, one of the big risk factors of having sleep apnea is venous thromboembolism. So people who have sleep apnea, it causes your blood to be thicker. And how does it cause it to be thicker? That's just how God made us. We try to compensate. So when your oxygen level drops, your body's going to say, I need more red blood cells to, to try and carry the little oxygen that I'm seeing. Okay. But by trying to compensate, you can have a red blood cell count that is too high. And so that makes the thickness, the viscosity of the blood thicker. And so you have a thicker blood going through the same size blood vessel, and so it's easier for it to clot. And so we know for a fact that sleep apnea, particularly severe sleep apnea, increases the risk of venous thromboembolism. So you may get clots in your legs, you may get clots in your pelvic vessels. Those are nuisance. But when they break off, they launch in the pulmonary circulation, in the blood vessels to your lung, that'll kill you. Okay, so that's another complication of sleep apnea that I failed to mention, but it's very important. And thanks for the question, because it helped me it reminded me to bring that point out. So thromboembolism is a real a high risk factor for patients who have moderate and severe sleep apnea.
Okay, and can losing a significant amount of weight help with sleep apnea?
Most definitely.
Okay.
The more weight you lose, the less pressure that we're going to need to correct your sleep apnea. Okay, so we look at the chip. You lose weight, we decrease the pressure. You lose weight, we decrease the pressure. And so if you get down to your ideal weight, then you may get off your machine. You may not need it. But the reverse is also true. You put on weight, we got to increase the pressure in order to correct you. So when we download your chip and we see that you're no longer corrected, we got to go up. Okay, and you bring your chip back in 4 weeks, you're not corrected, we got to go up. Okay, or we have to bring you back in the sleep lab and repeat the test and correct it, and then reprogram your machine. Okay, so losing weight is always a good thing in sleep apnea. Okay, putting on weight is a health hazard.
And we'll take 2 more questions. Sleeping on the left or right side, which would be the preferred side to sleep on?
It doesn't matter. You ask your wife, do you want me to look at your face or you want me to turn my back to you?
Okay, great. And then we have
happy wife, happy life.
I noticed that emphasis is on weight, but what of a person who's 5'11", weighs 160 pounds, over 50 female, but snores terribly?
Yes, it's the person's anatomy. One of our cardiologists in the community sent me a patient with sleep apnea. So I said to myself, now why is he sending me this tall, skinny woman with sleep apnea? I'm sure she doesn't have sleep apnea. And so when we did the test, to my surprise, she had very severe sleep apnea. So it's your anatomy. Some people just have a short chin and so they obstruct. Short chin, and although they're not obese, because of the anatomy, or they have a big tongue, because of the anatomy, they're going to obstruct. And so you can't just look at it. So, oh, the patient is obese, he got sleep apnea. You got a number of skinny sleep apneas out there as well.
Okay. All right. Are there any questions that I may have missed that persons in the viewing audience would like to ask Dr. Moss before we bring forward a person to say thanks?
I think we have covered most of the grounds for general knowledge.
I see a question if you accept Colina insurance upfront, or would you have to pay cash and submit?
No. All of the major insurances are accepted.
Assignment of benefits, okay.
Yeah, with assignment of benefits. Most of the insurances pay 80% of your consultation, studies, as well as machines. So once you've met your deductible, you're pretty cool to go.
And is a primary doctor referral required?
We prefer the primary physician send, but individuals may call and self-refer. In any event, we still have to send in pre-cert to the insurance for them to review, and they determine if they're going to pay your bill or not.
Okay.
But we accept referrals from the primary care physicians, as well as individuals may call and make appointments to come and be seen and be evaluated.
And do you just service the machines that you prescribe to your patients, or do you also service the ResMed machines?
We prefer ResMed and Respironics because we have the hardware to download the information from their chips. But sometimes the technician, she would go online and figure out the off machines and try to get into it. The thing is getting into the machine, because each manufacturer, they have their own ways of of getting into their machine, into their programs. And so once we can get into the program, we can see what the individual, the patient is doing and help. But preference is Respironics and ResMed, and they tend to make the better machines as well.
Okay. All right, thank you so much, Dr. Moss. Ms. Rogers?
Good evening to everyone. And Dr. Moss, we appreciate you so much for partnering with Bahama Health Family Guardian for such an informative session. By the number of questions we have, we are sure persons are more enlightened. They understand more about sleep apnea. And we just hope that they will continue to, I guess, reach out to you. I also want to thank those in the audience, some of our clients. I see some of the Bahamas Academy alumni. Hi. Good for joining us. We have the monthly doc talk, so you can always visit Bahama Health's website. But again, Dr. Moss, Family Guardian, Bahama Health, we are so pleased that you've consented to speak on such an informative topic. And you can stay on if you have or want to see further information about Bahama Health. We will also have some more information on Dr. Moss in case you were not at the beginning when we started our slide presentation. But again, good evening to everyone.
Good evening.